Welcome to Variations 4, Musculoskeletal Unit. We'll be covering questions 1 to 3 in this video. Osteomyelitis, bone tumors, and amputations. We're looking at maps 1 to 4 for that. What is osteomyelitis? In essence, it's a microorganism growing inside of the bone. It may start out somewhere else, like in the bloodstream, for example, and somehow it works its way into bone. Painful and dangerous. Lab results here are basically markers of infection and inflammation. ESR is defined and described down here. So are 2 imaging techniques used to diagnose. Here's our list of diagnostics, some diagnostics. And here's a list of some interventions. Antibiotics, of course, analgesics, and possibly even surgery to get rid of necrotic bone. The danger with necrotic bone is that you can get bone fragments separating and turning into dangerous emboli. Lungs, brain. The patients that I've met with osteomyelitis were IV drug users injecting into various places, even the neck, because they'd run out of veins in the arms and legs. They created abscesses in those areas. An infection had entered the body and created an abscess and worked its way into bone. These people were in pain. They needed a heavy course of antibiotics, and some even needed a bit of surgical debridement. The next question asks us to talk about bone tumors. We have enough basic knowledge of cancer and its treatment modalities. So in terms of bone tumors, the symptoms are fairly nonspecific in terms of the pain, fever, increase in white blood cells. Serum calcium might be a bit of a giveaway that bone is having pressure put upon it by tumors, maybe even being destroyed and releasing calcium into the bloodstream. There's a nice list of symptoms here, although they are fairly nonspecific. As with any cancer, metastases is a risk. Here's some diagnostics. And the treatment's fairly self-explanatory. Fairly standard and explanatory based on what we're seeing. Pancytopenia, as we'll talk about in a later unit, is a decrease in all cells. This is the problem with chemotherapy. As necessary as it is, it causes a decrease in all cells of the body. This has its own problems, which we'll talk about later. Amputations. What are the causes? What are the conditions that necessitate an amputation? What limbs are most often amputated in the Western world in a hospital setting? Perhaps if we answer that question first, then the former question will be much easier. The most common amputations you're going to see in a hospital in the West here are below the knee or above the knee, but basically lower portions of the lower extremities. So the lower portion of the legs, as I said, above or below the knee amputations are by far the most common. So in essence, anything that compromises circulation to that area and therefore compromises wound healing to that area, increases the chances of needing an amputation down the road. These three boxes up here can most certainly coexist, often do coexist, and pretty much any one of them on their own can lead to, but especially in combination, can lead to a decrease in perfusion to that lower extremity. Side note, constrictive footwear can actually contribute to this, especially in diabetic patients who need to be doing frequent foot care. Need to be really careful about what they wear in terms of footwear and examine their feet every day. Why that point is being noted in here is because once a wound begins in the foot, it can be very difficult for it to heal because of what we just talked about here. And if it's not managed properly, it can become infected. And the combination of the underlying conditions with the infection can leave surgeons shaking their heads saying, I'm sorry, but you're either going to run the risk of having sepsis down the road in this non-healing wound, infection leading to sepsis, or we just amputate. Fortunately, it's a much too common story. Circle, in terms of diagnostics, you have some imaging studies here. In terms of treatment, if you're lucky, you can correct the underlying problem. Whichever one it may be. You might need revascularization surgery, a femoral popliteal bypass. We'll come back to that in a minute. But if all that fails, you're going to need an amputation. Symptoms are fairly self-explanatory when you consider that the issue here is decreased circulation. And this is what I'd said above, the need for amputation. These are other factors that could contribute to the need for an amputation, although they're not as common that I've seen out in general surgery. Before we move on to the head to toe diagram, let's just take a step back here and look at this revascularization surgery. So let's assume that at some point there is an occlusion here in the middle of this femoral popliteal artery carrying blood down to the lower extremity. You've got the femoral up here that turns into the popliteal. This is the red part. It turns into the popliteal artery around about the knee. So it's kind of like a highway that changes name partway through. Imagine there's a block at the same level of around C here. What they'll do is they'll take a saphenous vein, harvest it, which is a superficial vein in the leg, and they will join it to here at point A and join it at point B, and then the blood will flow from A to B, bypassing the block. Your patient will come back with well approximated wounds all the way down the leg where they harvested and put in this vein to bypass. This is called a femoral popliteal bypass surgery. If they're lucky, this will restore circulation to the lower extremities and they will not need an amputation. So if we just go back here now to the head to toe diagram, was the last bit we have to talk about. Just scanning down through here just to see if there's anything that's not completely self-explanatory. Again, we're on the topic of amputations. So this is, say, someone who was not a candidate for a femoral popliteal bypass. Yeah, typically those patients are ones who have really bad wounds in their foot and it's just not going to heal and it's too late. Restoring circulation is just, it's too far gone. I've heard doctors talking to patients literally saying, look, man, you got days if you're lucky before sepsis sets in. So what do you want to do? You want to risk trying to fight this with antibiotics, which, they, in their opinion, is not they don't think it's going to work, or we're just going to cut this thing off. And that's the crude part of the conversation. So imagine they've had the amputation. Then I think a lot of what's in the list here is fairly self-explanatory. Phantom limb pain is described as kind of what would sound like a neuropathic pain. In fact, that is the origin of it. It's a neuropathic, it's a pathway in the brain that's causing this sensation to persist. So because it's neuropathic in nature, of course, anticonvulsants such as gabapentin and antidepressants such as nortriptyline can be useful in treating phantom limb pain. Narcotics, other alternative methods might help too. But the biggie here, the big point is that ambulating with the remaining limb and just the course of time, most people report that the phantom limb pain eventually goes away. Most post-op patients are at risk for atelectasis. Anyone who's not moving around enough, not taking deep enough breaths, not coughing and deep breathing, all this type of stuff, moving secretions around the lungs. Anyone who's not doing that is at risk for atelectasis. You can get atelectasis lying down at home. Constipation risk. This is all fairly intuitive stuff here. Compression wraps are something that you need extra training for. Usually you would end up doing them in the community, but in the hospital you need to be trained too if it's in your scope to do. And that is kind of helping to mold the stump that's left, trying to mold it so that it can fit well with the prosthetic if that's the course that the person is taking. Just some side notes here. Amputations, the surgeon usually wants to do the first dressing change around post-op day 5. That might change, but depending on where you're at. Foot, ankle, wrist, hand dressings. This is a totally separate point, non-amputated, but if someone's had surgery on the foot, ankle, wrist, or hand, typically the surgeon wants to do those dressing changes. Just that's a total side point, but just relates to ortho. Check your orders, of course.